We're going to talk about essential knee exam and how to get through an office visit, try to be it relatively efficiently. We're going to go over like most of the parts of the exam. In an office visit, you want to be a little bit more focused, and you're also not going to be able to do all of these things in the office visit. In fact, I think if you do some of them, the patient might try to knock your block off because they won't be happy about it. So, especially if they come in with a big effusion. Disclosures. I know we don't spend a lot of time nowadays talking to patients and trying to get to the bottom of an injury or an illness, but I find that in sports, 95% of the diagnosis can be retrieved by just asking the right questions. So you want to ask quickly, how did this happen? Or is this a chronic thing that has been ongoing for a lengthy period of time? What was the mechanism? And all these things can bear out in what the diagnosis is. Where specifically does it hurt? I always laugh with my teenage patients. They always say, in my knee, and I'm like, I know. That's why you're here. Can you be more specific? They just roll their eyes. Did you hear or feel a pop? That can be somewhat ominous sometimes. That can be a sign that maybe there is patella dislocation, ACL or a ligament tear, perhaps even a meniscal tear. Swelling is an important thing to ask about too. Did you hear, was it immediate onset within a few hours? That oftentimes indicates that there's bleeding in the joint and a more significant injury that probably needs advanced imaging. Or is it delayed? Oftentimes lower grade meniscus tears, arthritis, those things tend to be due to overactivity and crop up the next day or a day after. Do they have absolute locking or an inability to go through full range of motion? Sometimes hard to tease out. Patients may say they have locking and it's actually like catching of cartilage flaps and things like that, but do they feel like something's jamming up? There might be a loose body in the knee. Are they unable to fully straighten their knee out after an acute injury? That can be a sign, I think Dr. Lanzon talked about it, of a bucket handle meniscus tear where they were squatting down and immediately they felt a pop, and then they were unable to straighten their knee out. Sometimes people are unable to straighten their knee out the next day after an injury because of stiffness. That's a little bit different type of thing, but you have to keep that in the back of their mind. Somebody has an acute injury, and immediately they're unable to straighten their knee out. That may be a bucket handle tear of the meniscus that's flipped to the front, and you need to get that patient on crutches, non-weight bearing, and get them referred for advanced imaging or to an orthopedist. We see lots of patients in clinic that unfortunately have delayed evaluation. One of the radiologists was just telling me about one that they saw the MRI yesterday and they called the primary care doctor and said, get that person on crutches and to see an orthopedist because they had a bucket handle tear and had been walking on it for 6 weeks because nobody knew the wiser. So those things, if we get to them quickly, we can fix them. If people walk around on them for a lengthy period of time, we have to take the whole meniscus out that's flipped, so that's not good. Again, history, traumatic versus atraumatic, sudden onset versus insidious. How long have they had the symptoms? What things make them better or worse? Is it pain or is it instability? A hard thing to tease out also. Instability when the knee's giving out forward can be just due to weakness or quad inhibition. When it's giving out to the sides, patients describe oftentimes this type of shifting mechanism, that can oftentimes be due to a ligament instability issue. All right, and then you don't want to miss these things. Significant night pain, especially in kids, fever, weight loss, limp. You need to think about tumor or infection. And always check the patient's hip or back. Kids, especially young males, about 13 that are a little bit heavy, can have a slip capital femoral epiphysis, and oftentimes they present with knee pain, and it's actually the hip that's the problem. Back pain, as we know, can refer to the leg, and patients think that it's knee pain or foot pain. So, all right, so now we're going to switch to the actual exam after me talking too much. So Trevor, my lovely assistant, is going to be our model. The first thing I do oftentimes when patients come in is I try to take a little gander at how they're walking down the hall. because I was walking in here from the parking lot, and I actually saw someone what we call a windswept deformity, where they were knock-kneed on one side and collapsing in, and varus on the other side. I've heard about it, but I'd never actually seen someone walking. And I was trying to take a video of it, but I didn't get to do a good job. I took too short a thing, but I was like, wow, that really windswept deformity. So that is, I'll do it for you. He was like walking like this. So one knee has medial compartment arthritis and one knee has lateral compartment arthritis, but I've never actually seen this. So I'm gonna move this over. So I'm gonna have Trevor walk towards me. He's gonna demonstrate a varus thrust that Michael's gonna take from the backside. So his right leg is collapsing outward. So that can be due to a ligament insufficiency on the outside of his knee, but more commonly that's what people develop when they get arthritis in the medial compartment, in the inner side of his knee. So his medial side collapses in, and then he kind of stretches out the lateral side of his knee because he's doing kind of like this, like I'm doing also. So I look at people's gait. Are they limping? Next thing I do from a standing position when they're actually in the room is I go through a few meniscal tests. And I have kind of this 4 to 5 test series that I go through before I think this person needs an MRI to evaluate for a meniscus tear. The first one is that we have someone do a deep squat, and I mean butt to floor. And I ask them where they have discomfort. And this is sometimes hard for older patients, but if you can get them down to even like this and have them rise up, that'll give you some information. If they say pain's in the front of the knee, then that's patellofemoral pain. That's cartilage wear behind the kneecap. That's not what I'm looking for. Especially with medial meniscus tears, which is the most common type of meniscal tear, especially with older patients. If they say their pain localizes to the inside of the knee when they're pushing off to come back up, and maybe even they feel a click, then that suggests that they have a medial meniscus tear. They can also get pain on the outside, would indicate that they possibly have a lateral meniscus tear. So you're asking them to localize. Anything in the front here is patellofemoral pain until proven otherwise. It has to localize to the sides as they push off to come back up. Then second meniscal, there's one positive test. Second test is what we call a Thessaly's test, which is actually also quite humorous if people have bad balance. So you can chuckle, and then you can try it yourself, and it's not that easy. It's a newer test, and it basically is you're compressing the meniscus and you're twisting on it. So sometimes people are like, oh, my balance is poor. And I'm like, no, your core is weak. That's why you need to work on this. But you're asking again, do you have pain that localizes to one side or the other? If I'm worried about a medial meniscus tear, Trevor will say, and if he's got a positive Thessaly's, that it hurts on the medial joint line as he turns this way. The other one, if people are really bad with their balance, I ask this kind of equivalent question. Trevor, does it hurt you when you plant your foot and try to get into the passenger seat of your car? Because it's kind of the same mechanism. Oh, I don't do that. I have to sit down and then lift my legs up. So that's the equivalent Thessaly's test. Last test from this position, which I may not do with an acute injury, because I don't think people will be able to do it. But maybe when I'm looking at does someone need to go to rehab for working on their core or strength, or they have patellofemoral pain, is a single leg squat test. So this is basically kind of like almost a pistol test. I have someone squat down with the other leg out in front, and of course Trevor does a perfect one. And I'm looking for, does the knee collapse? Is their quad super shaky? And this is my test for basically returning to running. If someone can't do this, or they're going into like valgus collapse, or my personal favorite is they do this and they're not even bending their knee, then they're not clear to run after surgery. So really, people should not be running if they can't do 5 of these. You don't have to go as low as Mr. Showoff over here. But if people need to be able to, do 5 of these things well without the knee collapsing in. So those are the things that we do in the standing position. Then I have someone lie down. But again, you're going to be selective. If someone comes in with a big, huge swollen knee from skiing, you're not going to have them do a single leg squat test. In fact, you probably can't have them do the squat or the Thessaly's. So let me have you swing around this way. All right, so then the next thing we do is, take your shoes off. Hopefully you wash this morning. Okay, we're going to have the patient lie down. I try to ask the patient to keep their head down, because if they lift their head up to see what you're doing, then they're not. No, I was going to make a joke, but if they lift their head up, they tend to tighten their quad and you don't get as good an exam. So I try to tell people, like, I know you want to see what I'm doing, but I'm not going to pull a fast one on you and do something stupid. But you want to check good knee or bad knee versus good knee. So I check motion in terms of hyperextension. Trevor hyperextends for some reason more on the left side than the right side. And then I have them show me what their motion is in terms of flexion. So bend your knee up. Okay, so he gets about 140 degrees, and then bend the other one up. And I use the good one as a reference to see. So he's got full flexion, a little bit more hyperextension on the contralateral knee. I don't do this. I've had my residents do this. Someone with an acute knee is not going to be happy if you just force them into flexion and they've got a big swollen knee. They're going to be really unhappy and pain and in a lot of discomfort if you like check what their motion is. So we've established he has good motion. Then you go and I check for swelling. Swelling sometimes is a little bit difficult to tease out, but what you can do is kind of milk the swelling down from the right above the patella, because there's a big area called the suprapatellar pouch where fluid collects, and you milk it down, and then you can palpate how much swelling there is. Now, a huge effusion, generally you can't even make the kneecap out, and that's like pretty much you're thinking about getting an MRI because something significant happened in the knee. A mild effusion, I'm going to show you on this knee here, Mike. You'll lose this dimple that's to the medial side of the kneecap here that Trevor has, and it'll puff out. A moderate effusion feels boggy, but you can still make the kneecap out. It's somewhere in between. So mild is you lose this dimple, but you can still make the kneecap out. Moderate is there's swelling on both sides, but you can still see the kneecap. But a large effusion is the knee's like the size of a grapefruit, basically. So everybody always thinks that their swelling is the biggest that there ever was, but when you ask them, could you make your kneecap out right after the injury, then that will at least tease out maybe they didn't have a huge effusion. The next thing we do is we palpate for the joint line. This is the third meniscus test. We're looking for meniscal tenderness. So I'll bend the knee up to right angle. Hopefully, the patient can bend to that. And I'll find the bottom of the kneecap. Now you can surreptitiously put your hand on your knee below the table if you want to, and you can go through this whole test because it's in, so you just nobody's doing it. Okay, fine. All right. Find the bottom of the kneecap with the knee at 90 degrees of flexion, and you go on either side. This is the patellar tendon. If you go right on either side of the patellar tendon, there's two soft spots right above the tibial joint line. Those are actually where we do our arthroscopic portals for surgery. So if you can find those, you're ready to be an orthopedic surgeon and do sports medicine. So, all right. So we're going to start on the lateral side of your knee. This is the soft spot. If you get offline, you're going to feel very hard areas, which are the bone, the tibia, or the femur and the tibia. So I palpate, and I really stick my thumb in there, asking patients if they have discomfort. I palpate here. Then there's kind of a hard strap structure as we go a little further back on the lateral side. This is always a trick question. What do you think this is that I'm palpating? Still hearing LCL. There you go, IT band, okay? It's just like a trick question. So the IT band comes down, crosses the lateral joint line, and attaches to Gertie's tubercle. So that's the first thing you're going to feel, and it's maybe about an inch wide. Then you go back a little bit further, and there's a strap-like structure, almost like kind of the thickness of a pencil that goes from the lateral epicondyle down to the fibula, and that is LCL, right? So if you're any of you people that are surreptitiously touching your knee under the table, if you cross your leg over the other one, it's really going to bring it out, and you'll be able to feel it really well. So Trevor has a great one, okay? Then bend the knee back. You put your thumbs back right behind the LCL, that's posterior joint line, oftentimes a place where people have discomfort after they tear their ACL because of the bone bruise. Then biceps, the hamstrings, and then posterior joint line. So those are good areas to palpate if you're suspecting a lateral meniscus tear. Most commonly, they occur in the posterior horn. Then we go back to the front, we find our bottom of our kneecap. I'm going to switch to this one. The medial side of the knee. Discomfort in the front tends to be more cartilage related. It's the medial femoral condyle. If someone says it's sore there right on the medial femoral condyle, I'm thinking maybe this person has some early cartilage wear or arthritis, or maybe a chondral defect. So we go back down to the soft spot, we come back, then we feel another strap. There are straps everywhere in the knee. What is that? What goes from medial epicondyle down to the tibia? MCL. That wasn't a trick question. Okay. I know you guys are trying to think, is there something like the IT band on the medial side of the knee? Well, there is. There's semimembranosus. MCL. So if they have tenderness there, could be the meniscus underneath, could be an MCL sprain. So the way to check is like you go down, you go, oh, Trevor, do you have discomfort on the tibial side of the MCL? No. Do you have comfort as we go up to where it attaches to the femur? Yes. Well, maybe we're thinking MCL. And you combine that with other exam things, the questions you've been asking. Maybe Trevor got hit on the outside of his knee when he was playing football or soccer, then I'm thinking more MCL. We go back down to the joint line and find the soft spot again. This is posterior medial joint line. This is oftentimes where people have discomfort when they have a medial meniscus tear. And then all this stuff back here are the medial hamstrings. Trevor has huge ones. It's hard to get around. And then we go back behind, underneath and back to the posterior joint line. So I look for tenderness here and then tenderness up back here behind the posterior joint line. So that's our third meniscal sign. We did McMurray's, Thessaly's, and joint line tenderness. The other thing we can do in terms of tenderness is just palpate the back of the kneecap. I'll tilt the kneecap up and feel behind it on both sides. If that's tender, then oftentimes that means maybe they have a little patellofemoral wear or tenderness. And I can also check for patella instability in that teenager that maybe says they think their kneecap popped out, and you can check to see if I can push the kneecap over and it's going to the other room, then I'm thinking, well, maybe she did dislocate her kneecap. So, all right. So there's also an apprehension test where you do this and the kid almost takes your head off because they don't want you to dislocate their patella again. So then the last thing that we do in terms of a meniscus test, the fourth meniscus test, is McMurray's. Again, this one you don't want to do. If someone can only bend to here in the office, I'm not going to do a McMurray's test because patients don't like it when you hyperflex their knee when they have an effusion. So I check, make sure they have pretty good motion before I do this test. So basically, let's see, I'm going to bring the knee up, and I'm going to put my fingers on the joint line on both sides, but I'm specifically interested in the one that he's already had positive tests for. I'm going to hold the foot with my ankle, bend it up, and about here, before I get to full flexion, I say, are you okay with this? Not going to hit me? Okay. All right. I bend the knee up to, about 100 and probably about 130 degrees, and I've really got the hip flexed up. This is the key to this. And if you go to small group workshops, I'm going to say you didn't bend it enough. What we're trying to do is compress the meniscus and torque on it to reproduce the patient's symptoms. So if you get kind of wussy about it and you do it down here, you may not bring out the patient's symptoms. You really need to get it up here. That's why I want to make sure you can tolerate it. Fingers on the joint line, and then I do this kind of pendulum thing. And John, are you bringing up that video too? I'm rotating in and turning also, and then I'm rotating out like this. So if I'm worried about medial meniscus tear, I'm really concerned about like rotating in, doing a varus stress and trying to catch that meniscal flap, and then rotating out for the lateral meniscus. So pain to the inside when I do this and I'm rotating suggests, and it's on the medial joint line, suggests medial meniscus tear. If Trevor says it hurts out here, I feel a click, oftentimes that's just the IT band clicking, because I'm also stretching this. I'm squeezing the inside, stretching the outside. If I do a valgus McMurray's, where I'm going into valgus, closing down the joint line, and Trevor says it hurts here on the outside, then that suggests a lateral meniscus tear. What does it suggest if it hurts on the inside when I'm doing this test? Maybe MCL sprain, because I'm opening up the medial joint line, I'm stressing the MCL. So think about what you're doing when you're doing the test. So, okay. All right, and then the last thing we do in supine position is some of the ligament exam tests. You can check your ACL this way. I have a better way that I prefer to do it, just because I have football players that are twice as big as me, and they sometimes try to help me in the supine position. But the first thing you want to do is anterior drawer, which is an ACL test, but it's not as sensitive and specific as a Lockman's or a pivot shift, but I'll show you. Basically, this is when you really want to make sure the patient has their head down, because if Trevor, pull your head up, pick your head up, If Trevor picks his head up, he tightens his hamstrings a lot and his quads, and it'll affect your exam because the patient's basically guarding and preventing you from chesting for laxity. So put your head down. It's like amazing the difference. Like now you're nice and soft. Those massive hamstrings. Okay. So anterior drawer, you put your thumbs on the joint line. Knee is at 90 degrees, and you're pulling forward. Not as sensitive and specific, as I said, as Lockman's or pivot shift, but you're pulling forward. The other ACL test is the standard Lockman's test. Is you pick the patient's leg up to about a 30-degree angle and try to get them to relax. And you're putting your hands, I'm going to switch to this one too also. You're putting your hand, your lower hand on the medial joint line and the thumb in the front, and you're trying to check for translation in this direction. Can you see that? There's a video too that John can show you. I don't know, John, can you throw that up there because it's a little bit better? John? There. That's like standard Lockman's tests. That's a positive Lockman's, obviously. It's about a centimeter translation. So this is hard to do if someone has a big leg or if they're a football player and they think they had to help poor little old me do this exam, and then they hold their leg up and they're a little loosey here. I don't know what's going on with that knee. Now I'm going to make you paranoid. If someone's big, they're going to try to assist you, and then they're firing their muscles, and you can get a false negative exam. So that's why I do this other test that I'll show you in a little bit. So that's the Lockman's exam. The last test is a pivot shift exam, which really hard to get patients to relax for this, especially after acute injury. It's probably the most helpful in terms of making a diagnosis, but oftentimes you have to do it in the operating room. But it will also be positive with someone who's chronically ACL deficient because they're kind of used to their knee giving way. Basically what the pivot shift is, and see Trevor's already like guarding, is you are putting the patient's knee in extension and loading the knee axially like this. So I kind of lean into it. And then you bend the knee up just a little bit and you see if there's a shift. If someone's ACL is torn, the tibia is sitting a little bit forward. As you bend the knee up, the IT band tightens and it'll pull the tibia back into the correct orientation. You'll feel a shift. You don't always see a shift, but you'll feel a shift. But it's hard. The residents have a hard time doing this. A lot of times we teach them how to do this in the operating room when the patient's asleep and they're not guarding. But those are the three elements that John's projected on the screen. So, and you have to check side to side because sometimes people have a mild shift and it's just their norm. They're very ligamentously lax. So in this, I think it's the next picture. This is a patient who has a collagen disorder, and you can actually see the shift. You see how it reduces? So this is somebody I took care of about 8 years ago, and it's like the one that you can actually see it instead of just feeling the shift. But you see the tibia sits forward, and then all of a sudden it just clunks back because the IT band tightens up and shifts back. So it's a hard thing for you to do in the office. It's one of the things I usually do in the office, but not when the patient has an acute injury because they're too irritable and they guard too much. All right, and then the last things that we do, swing around this way. Are in the sitting position. I find this to be much more helpful in terms of all the ligament tests, except for the PCL. I forgot the PCL. Sorry, my bad. PCL injury. Got ahead of myself. The one thing you have to do in this position with the knee at 90 degrees is the PCL test. PCL tests. Again, I'm always checking to make sure hamstrings are relaxed. I put my one thing you can do is look for a sag. Oh, you had an ACL done here, huh? Okay. Well, who's your surgeon? No. I just noticed that. So you can check for a sag. You can bend both knees up to 90 degrees, and I tend to kind of look from the side and make sure that there's not a sag. And John has a picture that shows someone with a sag from a PCL injury, but you'll see that it looks like it's kind of almost bowed this way compared to the other knee. So that's one test. It's kind of a sag sign. It's kind of drop back. I think the next picture also, John. Maybe not. Next one. There's one coming up, I think. But for the posterior drawer test, you bend the knee up to 90 degrees. Again, you put the thumbs on the joint line. Make sure the patient's relaxed and they're not using their hamstrings to pull the tibia back or quads. I pull forward a little bit and then I push back. John, you got a nice stable knee. what you're looking for is the tibia going back in relationship to the femur, like this patient here. I pull forward and then I'm pushing back. A grade 2 will be that the tibia on the medial side will go flush with the femur. In a normal orientation, like Trevor has, I go up, and then the medial femoral condyle is about 1 centimeter back. That's normal orientation of your knee. In someone who has a sag, they may be flush. So what I'm doing is I'm pulling it forward and then pushing back just to see where the tibia ends up in relationship to the femur. A grade 3, which is the highest grade and usually surgical, is that the tibia actually goes a little bit behind the medial femoral condyle. So that's a PCL test. That patient in that video had a grade 2. All right, now we go to the sitting position. So we can't do those tests for the PCL in the sitting position, but I can do a lot of the other tests. One of the first things I do if someone has patellofemoral instability is I'll check tracking in this position, patella tracking. So I'll have the patient straighten the knee out and just watch how the kneecap tracks. In Trevor's case, it's like, right straight up. But you may see patients that as they straighten their knee up, the kneecap goes bloop over the side. That's a sign of patellofemoral instability. Oftentimes they stay in the groove until about 40 degrees and then they get into extension. Then it goes over the side. So it's J tracking or patella tracking, because I take care of a lot of patients with patellofemoral instability, a lot of teenagers. So then the other 3 tests are the ligament tests. So this is the way I do my ACLs. It's kind of like a modified Lockman. Slide back a little bit. Okay, so and I have a patient sit back like they're sitting on a park bench. Everybody seems to know that. This is why I wear pants in clinic. I have the ankle between my knees. And this also allows me to, again, check to make sure the patient's relaxed, because school teachers and accountants can't relax. And I always have to do this. I think school teachers have PTSD probably, but so I check and make sure the hamstrings are relaxed, because if the hamstrings are firing, I'm not going to get a good Lockman's. And then I put my stronger hand on the thigh and really use it as a vise almost to clamp the femur down. And then I take my other hand right below the joint line and I just quickly do a Lockman's. A lot of the residents, they like rip it like it's, and then you get all this other motion. It has to be a quick thing. You don't have to rip the leg off. And it's just a quick jerk, and you should feel an endpoint. So hopefully you guys will sign up for the small group so you can learn how to do this. This is an important test. But the key is getting the patient relaxed, making sure you keep the femur still, and then doing the orientation of the pull is this way and quick, not slow, not like this, because you can see it just looks like everything's moving all over the place, and Trevor has a positive Lockman's, and he doesn't. We'll check this one, though. Now he's guarding. Feels okay. You're good. Okay. All right. And then the other thing, but it's good because you can check one side versus the other, because some people have some ligament laxity that's just the way they are. There's a lot of variability among ethnicities in terms of how much people hyperextend, how much people extend, and intrinsic ligamentous laxity. It's pretty profound. Then the last thing we do is we can check the collateral ligaments from this position. So I bring the knee into extension, and then I unlock it a little bit to about 30 degrees. You don't want to bend the knee down too far, because then there's just a lot of laxity and not much stability. But you don't want to put the knee in extension, because all the bony constraints will keep everything constrained. So you unlock the knee to about 30 degrees. For checking the lateral collateral ligament, you put your hand to the inside and then put your the hand on the ankle to the outside, and I'm basically pushing out. And Trevor has some intrinsic lateral varus laxity, but that's probably normal for him. So then we do it on the other side for comparison. So the thing you're going to test, you put your hand on the opposite side, and you just push out. So that's normal for him. But you're checking side-to-side differences. That's why it's helpful to do this in the sitting position, because you can quickly check from one side to the other. Sometimes if I'm not 100% sure with an ACL injury, I'll check several times. So hands pulling in, and then the hand up at the knee is pushing against the ligament you're testing. Grade 1, it hurts, but you don't really notice a difference. Grade 2, there's a little bit of a toggle. In grade 3, you can run out of the room with the leg. It makes you feel sick to your stomach. Okay, then for MCL, Now we're going to check this ligament, so I'm going to put my hand on the opposite side, put the knee in full extension, and then unlock it to about 30 degrees. And then I'm pushing in, and then pulling out on the opposite side at the ankle. Okay, and then I'm checking side to side. You're good to go. You're cleared for sports. You can do a single leg squat. So, okay. So that's about it for the quick exam with all the explanations. So I'll take any questions. There's a couple. Do you want to show the LCL? I'm just going to show you the Barrett stress test for grade 3 is like literally, this is one of my soccer players from Cal that got taken out by someone. It kind of makes you feel sick to your stomach when it's a grade 3, basically. So, all right. Any questions? No? Everybody's got it. Okay. I'm just going to spot test you in the hallway. Okay. Okay. That's it.